I have no slides, so good news. So I have the daunting task of summarizing the topics of the day and trying to put it in some perspective for everyone. First of all, it's been a privilege for me to be involved with the decade since its inception in 1998. And I think those of you who were around in 1998 realize the almost unimaginable thought of creating a decade, building a movement. And I want to take this moment to congratulate Lars for his vision and leadership over the last 12 years, actually, of getting this unbelievable movement going. I think those of you who remember the decade of the brain, which was 1990 to 2000, you realize the significant advances that were made in neurosciences, neurology, and mental disorders. And I thought we could never surpass that. They really did a good job. But I would say that this organization under Lars's leadership has done a fantastic job. We have a much larger burden of disease, and the cooperation, collaborations that have been built in the national action networks and internationally have been phenomenal. And I think Lars and the International Steering Committee are to be congratulated. Well, the themes of today, I think you saw, were moving together and moving forward. And for us to realize that, you've learned a lot of lessons over the talks that were presented today. We started out in the research arena from Professor Katrina talking about AutoCure, which is a collaboration between 26 partners from academia and industry using rheumatoid arthritis and myositis as their prototypes. The aim of that project was to combine knowledge from advanced molecular studies in autoimmunity and genetics with knowledge from clinical centers around the collaboration to enable prevention and ultimately curative therapies from an increased understanding of causes and mechanisms of disease. This group studied risk factors, early signs of disease, adverse effects of treatment, and did a longitudinal follow-up on the patients involving different European countries, which is important. This collaborative effort brought out new knowledge in the prevention of arthritis, identified risk factors, particularly smoking, helped in the very early diagnosis of the conditions, also pointed out the fact, or identified the fact, that this is a heterogeneous disorder requiring individual targeted therapies, and then was able to look at the targeted therapies to see the long-term effects or adverse effects of those therapies. And probably the most important aspect of this, which emphasizes the collaboration, is that these 26 units had tremendous interaction on a horizontal basis that allowed researchers, clinicians, scientists to develop new collaborations which will lead to breakthroughs in the future. Professor Uhlig talked about one of the most important aspects of the burden of disease, and that's variation in health care and disparities of care which exist in every country. And this exists because there's lack of awareness, lack of knowledge, and lack of health policy priorities, which we talked about throughout the day. But what they've done to try and change this is create a platform, a musculoskeletal surveillance and information network, which will generate data, set standards, identify barriers, and then identify strategies to overcome the barriers. And this is critical for the advancement of a movement to improve the health quality of patients affected by the individual disorders. Professor Peter Brooks gave us a wonderful talk about the OMER Act. And I think every country where healthcare is paid for by somebody, whether it's the government or private payers, no longer just is willing to dole out the money. What they want is value. They want cost-effective treatments. And as you heard throughout the presentations today, you want to get rid of things that don't work, and you want to know what are the cost-effective treatments. And the foundation for clinical research is clinical trials. And for clinical trials to be done at the highest level, you need to have good outcome measures. And Professor Brooks outlined for us the status of RA trials prior to 1990 and the evolution of the OMER Act throughout the years and the process that it took his group to develop these important outcome measures. And again, like my experience is only in the United States, but everyone's looking for the highest level of evidence. And to get high level evidence, it's really important to one of the foundations of evidence-based medicine is taking in the patient's perspective. And Professor Brooks was the first one today to talk about the importance of including patients here in the development of outcome measures. This is critical, and it's one of the tenets of the bone and joint decade, as you all know, that's empowering patients. He outlined the process and also the multidisciplinary collaborations that were necessary to create these outcome measures over time. And I think this is a model for other areas, for those of us who are not necessarily working in rheumatoid arthritis, but other areas that the bone and joint decade is concerned with, is that to develop valid outcome measures, it's not just an orthopedic outcome or a rheumatologic. We need patients, we need other healthcare providers who are involved with taking care of these various musculoskeletal conditions. So I think this was a model of collaboration. Took time, took resources, but it's the way we need to be going in the future. Martin England presented a very important study about, and actually made me very sad, because in America we don't have this. That's about registries. And what you have here in Sweden is such a model of high quality population level registry. In the United States, the #1 DRG, or diagnostic related group in Medicare, which is our healthcare system that pays for individuals over 65 years of age, is total hip and total knee replacement. Yet we have no joint registry in the United States, and you have one in Sweden and Australia, which have provided tremendous information about alterations and use of healthcare resources. So your presentation was really exciting, how you learn about the incidence of disease, prevalence, comorbidities, the total burden of disease, risk factors, and then cross-linking data, but made me very depressed about what we don't have in a country which has tremendous resources. And then Neil Betteridge again brought us back to the patient. I think you heard Dr. Katz say, and I would tell you from my experience as an advocate in the orthopedic community, that when physicians advocate for more money, for more funds, it's viewed as self-serving, because that's what we do for a living. I'm a researcher, I need more money, etc. But patients are the human face of the burden of disease. And I think Mr. Betteridge pointed out very nicely that musculoskeletal systems are under-recognized, underappreciated, and underfunded. And to change policy, we need strategic collaborations to change health policy at the highest level. And that advocacy efforts, which we'll come to later on in another presentation, really need to be relentless. You can never let up. These are not just one moment in time, but they're continuous efforts, and they have to be done in a collaborative effort. And again, Mr. Betteridge pointed out, certainly better than I can, that this has to be patient-centered, even in advocacy, because this movement, the Bone and Joint Decade, is about patients. And then we had the privilege, I think, of hearing Stephen Katz from the NIAMS give an absolutely, I thought, fantastic presentation about his perspective on the Bone and Joint Decade. And I happened to be the president of the U.S. NAN at the time when we first met with NIH. And I recall the trepidation I had with that meeting, because this was the first, I didn't know what NIH would really say about the Bone and Joint Decade, or if they would view it in a positive light, or if they would view it the same way we did. But I think that first meeting in 2002 with the NIH, and them realizing that I wasn't coming just as an orthopedic surgeon, but I had my rheumatologic colleagues, I had my occupational medicine colleagues, we had physical medicine rehabilitation, national athletic trainers, physiatrists, etc. Everyone was at the table there, and he was kind enough to bring the other institutes at NIH there as well, so they could see what the Bone and Joint Decade movement held as a promise for collaborative efforts. And he outlined for you today the importance of trust between investigators, the importance of collaboration, and the wonderful things that have come about since the decade began with genome-wide association studies, the Osteoarthritis Initiative, this exciting Armed Forces Institute of Regenerative Medicine, Rare Bone Disease Research and Rare Bone Disease Network, and also the importance of the young investigator. I think, at least in orthopedics, and I think in many areas of medicine, the attractiveness of clinical practice is taking, and the discouragement of being able to be a researcher because of lack of funds is really hurting the future of all of our specialties. And NIH has really put full efforts into helping this young investigator process go forward. And I think Dr. Katz pointed out lastly that a big study in the United States with healthcare reform looked at comparative effectiveness, and they wanted the top 100 priorities. And you can see that musculoskeletal conditions were 5 of the top 100 where resources should be prioritized. So in our country, and I think NIH with its tentacles around the world and collaborations with the research institutes in various countries, realizes the importance of the bone and joint decade and are, I think, facilitating our efforts to move forward. After Dr. Katz, we moved into a different area. We looked at what progress has been made. Each of our speakers were asked to say what's the most important or most significant development in the area they were assigned to talk to and what's the future hold. And I think all of them had difficulty saying what's the most significant, because there are so many things that have been accomplished in the last 10 years that they really had to limit themselves to just 1 or 2 topics. Dr. O'Keefe pointed out 2 areas. He talked about inflammatory arthritis, and he talked about combination therapies, tremendous advances in inhibitors to TNF-alpha, and ability to block osteoclast resorption. He talked about tremendous developments in osteoporosis research, the use of bisphosphonates, anti-rank ligand therapy, and talked about the osteoarthritis mouse model, talked about knockout mouse models, and talked about the exciting future, which involves tissue engineering, material sciences, nanotechnology, gene delivery systems. I think what he made me feel at the end of the talk was that we are on the brink of major developments which will change the burden of disease. I think I'm not a basic science researcher, but I think that I felt tremendous encouragement by the research that's been done so far and the promise for the future. David Scott was then assigned to talk about the clinical sciences, and he pointed out in a very unique and thoughtful presentation, he based his most significant on most cited publications, economic impacts, and the recognition of the investigators for prestigious awards. And he highlighted several areas. One was the biologic revolution, which we heard over and over in inflammatory arthritis and connective tissue disorders. And he also talked about the exciting possibilities of curing osteoarthritis and understanding pain in the future with stem cell research and functional MRIs. And I think the breakthroughs in technology, all of which require a collaboration not only with basic scientists and clinicians, but also require collaborations with industry as well to have these major breakthroughs which will affect the quality of life of patients. Sorry. The next presentation came about what's been the greatest breakthroughs in medical management, and we heard Professor Kivian talk about that the major improvements again had been in inflammatory conditions and a little bit more limited in soft tissue conditions like back pain, pain syndromes, and osteoarthritis. And he emphasized more on the clinical aspect of early diagnosis and early disease modifying treatment, such that if you could intervene early and prevent the joint damage, you would not have to deal eventually with the late problems of joint damage and disability. Talked about early identification of markers, a new classification system both for rheumatoid arthritis but also for the spondyloarthropathies, and talked about the effectiveness of tighter control by the use of target setting. If targets aren't reached, then treatment is altered, and the improved results that happen with this approach and also the early intervention. He also was the first one, I think, to introduce the topic of personalized medicine, which I think we'll hear more about as